Thank you very much. It is my great pleasure to be here and to participate in this fantastic meeting. I had the opportunity yesterday and today again with this symposium. I thank the organizers and Hikma for inviting me. These are my conflicts of interest, and I will talk to you about SGLT2 inhibitors across the spectrum of ejection fraction and some practical issues. It is very clear now that over the last 30 years, we just paid attention to 50% of our patients with heart failure, which were those, at least the clinical trials paid attention to those that had an ejection fraction below 40. And now we recognize that heart failure is bigger than that, and approximately 50% of our patients have an ejection fraction above 40%. So the whole SGLT2 inhibitor programs, both for dapagliflozin and empagliflozin, started trials dedicated to the REF and to the PEF portions of the heart failure. Let's go to the evidence of dapagliflozin across the spectrum of ejection fraction. We have DAPA-HFpEF, which was the first to publish in patients with heart failure and reduced ejection fraction, 4,700 patients, and they had a composite endpoint of cardiovascular death or worsening heart failure, relative reduction 26%, and an NNT of 21. Very important that other trials have not been able to show the significance was for the two components of the endpoint, both for cardiovascular death and for heart failure hospitalization. And for the first time, this study, now we all acknowledge as something that we have it in our minds very easily, but this drug demonstrated it was useful for diabetics and non-diabetics, irrespective of therapy, regardless of higher or lower NT-proBNP, diuretic use, and eGFR. So these are the main graphs from DAPA-HF, and very importantly, and I think this is very relevant, dapagliflozin in HFrEF started to be significant after day 28. So this means that we should start dapagliflozin as soon as possible, because before the end of the first month, the curves already diverge in a significant manner. The other compounds of the event, worsening heart failure, 30% reduction, cardiovascular death, 18% reduction. After DAPA-HF in HFrEF, we have dapagliflozin in HFpEF, which was presented last year. The DELIVER trial. DELIVER is a very large trial in HFpEF, 6,200 patients, 72 years mean age, 44% woman, and as you can see, NT-proBNP is large for HFpEF, over 1,000. 16% were enrolled before 90 days of hospitalization. You can see here the comorbidities, classical HFpEF, 45% diabetics, 45% obese, almost all hypertensive, 89%, atrial fibrillation, a little bit more than 50%, and coronary artery disease. And very importantly here, as you look to the groups according to ejection fraction, there are a group of patients, about 18%, which had prior reduced ejection fraction and improved to HFpEF. So the DELIVER trial wanted to demonstrate if dapagliflozin was also useful in improved patients. The results are very, very clear again, 18% relative risk reduction. And again, if we look to the quick effect of DAPA in HFpEF, it's even quicker. So at day 13, the curves diverge statistically significant. And this means that we need to start thinking on giving dapagliflozin to our patients as soon as we do the diagnosis. When we look to the components of the primary endpoint, CV death or worsening heart failure, you name it, hospitalization for heart failure or urgent heart failure visits, all individual components were less frequent in the DAPA group. And this is a very important slide because it demonstrates that across the spectrum of ejection fraction, dapagliflozin is below the unity for cardiovascular death. And when we look to cardiovascular death and heart failure hospitalization, it's even more significant, and that is almost a flat line without any loss of benefit as ejection fraction goes up. Very interesting, this is recent data that I think it's worth mentioning. The efficacy of dapagliflozin was consistent, irrespective of background diuretic use or dose. So if you have patients with high doses or low doses loop diuretics, the benefit is the same. However, as you look in the center, the mean loop diuretic dosing increased in the placebo group in blue and remained stable in the DAPA group. So that means that we do not need to keep increasing diuretics. And I think on your right, even more importantly, DAPA reduced new initiation of loop diuretics by 32%. So if you are using dapagliflozin, which has this glucosuric and natriuretic effect, you do not need to use loop diuretics, which we know they are deleterious for our heart failure patients. And also very important, as we are today here, is dapagliflozin useful across the globe? Well, the evidence we have is this one, is the most recent in Europe, North America, South America, Asia. You will probably ask, what about Africa, which is data that we do not have, as far as I know. It is equally useful, and the results are reproducible, and they are all significant across the globe. One another issue that has appeared into discussion is whether SGLT2 inhibitors promote reverse remodeling. So we did this study, the DAPA-MODA study, to study the effect of dapagliflozin specifically in atrial remodeling. And we did this in patients with HFrEF and also with HFpEF. And our aim was to explore how the atria, as a good surrogate of heart failure in general, would evolve with dapagliflozin. As you can see, the study was positive with a reduction of 7.3% of LAVI max, but also the mass of the ventricle reduced by 13%, the volumes reduced, and NT-proBNP. So we now have a drug that is reducing mortality, it's reducing hospitalization, it's improving quality of life, and it's promoting reverse remodeling. With empagliflozin, we have similar evidence across the spectrum. So we have a program with EMPEROR reduced on your left with a relative reduction for the composite endpoint of cardiovascular death and hospitalizations of 25%. Hospitalizations alone, 30%. Unfortunately, cardiovascular death was non-significant here. In the EMPEROR Preserve, you see similar results, 21% for the composite and 27% for the heart failure hospitalization. Again, with empagliflozin, similar to dapagliflozin, these patients had nephroprotective effects by SGLT2. The EMPEROR pooled, combined, EMPEROR reduced, EMPEROR preserved, and the effects are what you see here. So ejection fraction did not impact on the effect of empagliflozin on cardiovascular death or first heart failure hospitalization. If you look to the curve or you look to the line, there seems to be some attenuation at ejection fraction 65 and above, but what is most important for you to look at is the p-value for interaction, which is 0.30, and this means it is non-significant. So we should consider empagliflozin also valuable across the spectrum. In the empagliflozin program, there is the EMPULSE trial, which is interesting because this trial evaluated patients with acute heart failure. And they found that patients that were treated in the acute phase, in the wards, in the hospitalized, were 36% more likely to experience clinical benefit than patients on placebo. So with all of this evidence, what the guidelines and consensus tell us, 2021, very clear, the ESC HFA guidelines, 4 pillars, dapagliflozin, empagliflozin, in the first foundational treatment together with the other 3 pillars. So they have become foundational treatments. And if you go to the 2016 guidelines, so just 5 years ago, 5 years before these guidelines, we had no evidence on SGLT2 inhibitors. So all these that it appears that we all already know so well, it happened in 5 years. And it looks like science is going faster and faster, and things are going at a super high speed. Because it's not only that happened in 2021, but we have this HFpEF consensus from the Heart Failure Association published in May this year, which provided a patient phenotype profiling for HFpEF, putting certainly treatment of DAPA-EMPA in the center with or without diuretics, depending on congestion, and then you treat the comorbidity, iron deficiency, ischemic heart disease, AFib, diabetes, hypertension, obesity, or COPD, with each one of these treatments. This happened in May. Also happened the 2023 ACC consensus. So we had all this consensus because of all these trials coming out. The ACC put this SGLT2 in the center of the treatment. They didn't put it green, but they didn't put it yellow. So they put it yellow in the center and surrounded by a green line, which was already introducing what was going to happen. And then depending on the phenotype of your patient, congestion, loop diuretics, and so on with MRAs, ARNIs, OARBs. And we have since the ESC Congress in the end of August, so it's just 2-3 weeks old, the 2023 Heart Failure Guidelines update. And this is very interesting because now we do have DAPA-EMPA with a class 1A indication according to the European guidelines, together with diuretics. We have DAPA-EMPA with a class 1A indication in patients with HFpEF, together with diuretics and etiology and comorbidities. And with all of this in mind, it so appears that I would launch a call for action to all of you, because what we need to do is early heart failure diagnosis. I think we are diagnosing patients too late, and we are waiting to have ejection fraction to do our diagnosis. What we tend to see, at least in Europe, at least in my region, in Spain, is that more than 50–60% of patients are first diagnosed in the emergency department. So the first diagnosis is because of an acute decompensation with severe congestion. And we need to go earlier. So we have just launched this consensus published 10 days ago. This is in the suspicion of de novo heart failure in the outpatient. When you have signs and symptoms of your patient, try to do NT-proBNP as soon as possible. Until now, natriuretic peptides were mainly used for ruling out heart failure. Here we are proposing natriuretic peptides to rule in heart failure. We have pushed this age-adjusted ruling. The younger patients, it's 125, 50 to 75, it's 250, over 75, it's 500. Why is this important? Because if you have suspicion of heart failure and these age-adjusted cut points, we suggest that heart failure here is very likely, and treat as appropriate. And treat as appropriate today in 2023 means manage congestion and treat with SGLT2 inhibitors. And then this consensus suggests that you do an echo within 6 weeks. I don't know what happens in your countries. In our country, echocardiograms from the GP until they are performed may take between 2 weeks to 6 months. And we cannot lose these 6 months, because it happens that dapagliflozin was useful within the first 15 to 30 days and was already avoiding admissions and deaths. So we need to, I'm just launching here this call for attention. We need to get these patients earlier to be able to start treatment earlier. Very interesting what happens in these new guidelines. Also, a recommendation for the prevention of development of heart failure in patients with diabetes and CKD. As you can see here, in patients with type 2 diabetes and CKD, SGLT2 inhibitors, DAPA-EMPA, recommended to reduce the risk of heart failure hospitalization or cardiovascular death with a 1A level. So now, which considerations do we have to consider for implementing SGLT2? First one, do I have to be concerned about my patient's age? Raise your hands, those who think that being older, over 75, should be a concern for starting SGLT2 inhibitors. Not at all. It's not a concern. I would say just the opposite. In these older, frailer patients with more comorbidities is where there has been more evidence of benefit. So no concerns on age. Number two, should I be concerned about my patient's kidney function? Well, it's again, I think the answer is the same. You should not worry about the kidney function. When your patient's eGFR is above 25%, you should just go for dapagliflozin, because dapagliflozin and SGLT2 inhibitors are nephroprotective. And as you will see in the trials over time, the decline in eGFR is much less than with placebo. So number three, should I have to be concerned about blood pressure? So do you have any concerns of starting SGLT2 inhibitors in patients with low blood pressure? Not much. I would say that the evidence suggests that we should not be worried about patients with low blood pressure. Number four, should I be concerned about other side effects? There was a strong concern at the beginning about ITU or genital infections, particularly in patients with very severe diabetes, uncontrolled diabetes. In the setting of heart failure, the 4 trials indicate that this is a very safe, these are very safe drugs, and the risk of suffering from an ITU or a gynecological infection is just slightly higher, but not something dramatic, and you should treat it as usual. So I would say that SGLT2 inhibitors are easy because it's a single dose, it's once a day, no titration. You can take them with or without food. You don't have to consider that. You can take it any day, but if you start in the morning, it's in the morning. If you start in the evening, it's in the evening, regularly. And again, early benefits. So the beneficial effects of SGLT2 occurred very early after randomization. So early administration of SGLT2s, I would say this is very recommended. So we need to identify early our patients and treat early our patients with SGLT2 inhibitors. Thank you very much.